Good evening. I'm Nancy Innermill with the Lincoln-Lancaster League of Women Voters. We'd like to thank you for coming tonight and welcome you here. We very much appreciate that St. Paul Methodist Church has made the church available for us. And we would especially like to thank Nebraska AARP for being our co-sponsor of this event, which is allowing us to film this presentation, and it will be available on Channel 10, which is the new health channel, over the course of the next month or so. So we're here to talk about the Affordable Care Act and what it will mean for you and for your families. And one of the key elements of the Affordable Care Act is healthcare exchanges. You've heard of them, or what in Nebraska we're referring to as health benefit exchanges that will go into effect in 2014. And the states have discretion as to what will be offered in the various health benefit exchanges. So it is important for people to pay attention to what's going on at their state level so they know what's available for them. Tonight's speakers are Jennifer Carter, who is Nebraska Appleseed's Director of Public Policy and the Healthcare Access Program. Jennifer has worked extensively on children's health care, particularly in the reauthorization of the state children's health insurance program in Congress and improvements to Nebraska's Medicaid and children's health insurance program, the Kids Connection. She also works on Medicaid reform. She earned her BA from Columbia University and her legal degree from Boston University School of Law. Prior to joining Appleseed 8 years ago, Jennifer was in private practice as an attorney in New York. Mark Innermill is Associate State Director for Advocacy with AARP Nebraska. He facilitates the participation of AARP members in the political process. He's worked in the field of aging for over 30 years. Prior to joining AARP, he served as the administrator for the Division of Aging Services with the Nebraska Health and Human Services Department. He earned his BA in Political Science from Kansas State University, and we welcome you here tonight and thank you for joining us. We'll ask that you hold your questions until the end of the presentations. The presentations will go on, it will include a PowerPoint for you to follow along with, and when we conclude that, then we'll be happy to take your questions and engage in some question and answer session. Thanks very much. I'll turn it over to you.
Great. I think we're going to tag team this a little bit and go back and forth, but I think I'm kicking it off.
You're sorry. Yeah.
Okay. So we wanted to do a little bit of background. Sorry. A little bit of background on the law, just very quickly to give you some context before we dig into exchanges, which is really the one of the biggest and most critical pieces of the law. So I think as most people know, on March 23rd, 2010 is when the Patient Protection and Affordable Care Act was signed into law. And we will refer to this largely as the ACA. Some people refer to it as PPACA, also if they use the full acronym. It took a long time for people to settle on an acronym. So it's either usually PPACA or the ACA. As we've worked with the law, and Mark and I have been working on this since pre-passage. It really, for us, it seemed to fall into 4 categories is a more easy way to explain what the law can do. One, it's about mainly improving access to health care coverage. And we do this largely through the exchanges, which we'll talk about tonight, and Medicaid expansion. Then it's about the affordability of healthcare coverage. So it's great if you have access, but how do you actually afford it? And that's where tax credits comes in and premium subsidies to help pay for it. There's also a lot in the law that's really about ensuring that the system is fair and that people get real value for their premium dollar. And that's where some of the important consumer protections come into place that really addressed a lot of the key complaints people had in the private system before the law was passed. And then there's also quite a bit in improving our delivery system in the hopes of controlling costs, and that's going to be a really important piece of the law as that moves forward, because I think most people agree the skyrocketing costs are what drive a lot of problems in our system. And so these are things like moving to medical homes so everybody has a consistent place for care and preventative care, and a bunch of pilot programs that can happen, and so things that we hope will be helpful. We won't be talking much about those tonight, but it's important to know that they're a part of the law. We also like to mention that 6 months to the day after the law was signed, several of the key consumer protections went into place, and then additional ones will go into place January 1st, 2014. But these are already helping lots of people. One of the biggest ones was it ends the denial of coverage for pre-existing conditions for children. This is huge for kids with chronic conditions like diabetes and other issues that may have kept, even if their parents had access to health care coverage, may have kept them from being able to participate in those family plans. It bans copays and out-of-pocket costs for certain preventative care measures like mammograms, but it also pays for immunizations on new plans. It prohibits a lifetime benefit on all plans, so that means this is really important for our friends at like the American Cancer Society. You can hit your limit really quickly if you have cancer and you're needing chemo, and so this bans a lifetime limit, and then soon in 2014 they'll actually ban annual limits as well, because some people still hit an annual limit and may be facing a gap in care before it starts again. It extends dependent care coverage to age 26 in all plans. So this is if you've got kids who are not yet age 26 and they don't have access to care, to health care coverage through their employer, you might want to look into this, and you can check into whether you can keep them on your plan, family plan, and they don't actually have to be your tax dependents. So there's real opportunity there. And one of the bigger things that thankfully I think we saw less of in Nebraska, but insurers cannot drop you when you get sick. And these are stories, real stories that we heard out of mainly other states where an insurer, you get sick and then the insurer goes back and reviews your history and says, it was quite literally things like, if you had told me you had acne when you were a teenager, when you filled out the form for insurance, I never would have offered you this policy, so now I'm going to rescind it and you won't get the coverage now that you're actually sick. So those are good things that are already in place, and even more of these types of things, like actually a ban on pre-existing condition denials for everyone, will begin January 1st, 2014. As a person with pre-existing conditions, I'm looking forward to that myself. And now the focus has really become the creation of health benefit exchanges, so that's what we were here to talk about tonight. There's been a lot of planning done to date, and there has been funding was built into the Affordable Care Act to allow states to plan. In January 2012, the Department of Insurance here in Nebraska obtained an initial planning grant of about $1 million to start the implementation work. And they actually released their report in October, and they hired 2 analysts to do this work, and they reorganized some of their team internally to start looking at what we might want to do for an exchange. Some of the preliminary questions were, do we want to do an exchange we have choices here. Do we want to do a state-based exchange? Do we want to hand it all over to the feds? Do we want to try to work something out with other states around us regionally? There was a lot of preliminary questions to be answered. And then, when they completed that, there's a second round of grants that are available to states that are referred to as not the planning grants, but the establishment grants. And there are 2 levels of establishment grants. Nebraska Department of Insurance applied for and got a level 1 exchange establishment grant, and that's for $5.5 million. And they're beginning, I think that's begun now. The level 2 grant is the big one. That is the one that gives you states in the tens of millions of dollars. Some states have gotten it, it's close to $60 million to really set up the exchange. It's about creating the infrastructure so that you've got that in place, and then part of what we have to do, which we'll talk about, is make sure that the exchange is self-sustaining. So the idea here is there shouldn't be the need for general fund dollars. This has been appropriated in the ACA to give the states the money they need to set these things up, and then hopefully set it up well enough that they can move forward on their own. Is this still me? Thanks. I still go, right?
Yeah.
Okay,
Yeah.
I'm still talking. In terms of establishing health benefit exchanges, and really the 2 main ways that we're accessing coverage, as I said, are exchanges and Medicaid coverage. So I'll talk about those briefly, and Mark will take that a little bit more in detail. But what are the exchanges? They are because it's sort of a word that doesn't automatically lend itself to a picture of what it is. But they are competitive marketplaces, essentially, where individuals can shop for private insurance, enroll in Medicaid and CHIP, public benefits programs. And the idea was to make this really accessible so that the information is clear. That's one of the key things about an exchange. So that if I'm looking at 3 Blue Cross plans and 2 United Healthcare plans, I'm comparing apples to apples in an easy way where I can actually understand, oh, this one's offering me more benefits or the kind of benefits I need for my family versus the other. And also, the regs have required that there'd be one application so that I'm not doing 2 different ones depending on who I'm applying to, or if I'm applying for this one and my husband's applying for another. The point is to make this really simplified and accessible. The exchange, really importantly, is also the access point for any tax credits to help you purchase coverage. So these premium tax credits that we've heard about, which Mark will talk more about, you can only get them when you purchase coverage through the exchange. It also will contain a lot of the strong consumer protections, some of which will apply outside the exchange. So we have our insurance market today for large group and small group, and then there'll be an exchange where individuals and small businesses can go purchase as well. But people, if you've got your insurance with your business right now, that will remain, and that will remain outside the exchange, so to speak, as if the exchange is a physical place. So some of those consumer protections will apply both places, but the exchange will have strong consumer protections. It will also have standards related to marketing. As I mentioned, the disclosure of information. There'll be some, as there is to some extent in the insurance market today, regulatory oversight of the value of what the insurers are offering, what they're charging, those types of things. Another really key part of increasing access is that Medicaid will be expanded to all individuals, including childless adults under 65 with incomes up to 133% of the federal poverty level. This is huge because I think one thing people don't tend to understand about Medicaid is it is not accessible to everyone right now. It is accessible to those who are aged, blind, disabled, or children up to a certain income, or sometimes what they call caretaker relatives, the parents of people who have kids. But you have to be, especially as a parent, you have to be extremely poor to access Medicaid. So it's not like just somebody who may be out of work and doesn't have an income right now can access Medicaid if they don't have kids or if they're not age blind or disabled. And so this is a huge, huge help to many, many people. States will receive, under the law, 100% of federal funding to pay for those who are newly eligible. So if you're for mainly these childless adults and other adults with kids who may not be eligible today because the eligibility level is so much lower than it will be in 2014. The funding will scale down to 95. It kind of scales down over a couple of years but 90% in 2020 and going forward. And Medicaid eligibility must be accessible and determined in the exchange. And this is going to be a key part of figuring out what Mark will talk about, this no wrong door policy. And can somebody walk in and buy a private plan or buy Medicaid, whatever is suited for them in the exchange?
Okay, so let's talk about the tax credits. The tax credits are probably the largest expense associated with the Affordable Care Act, but that's also where the greatest benefits will be realized for people who are purchasing insurance. What the Affordable Care Act does is it creates these tax credits to assist with the premiums for eligible persons with incomes between 100% of poverty and 400% of poverty. And in this year, that's $18,310 at 100% of poverty for a family of 3, $73,240 at the 400%. So in that range, there would be available tax credits to assist with a portion of the cost of insurance. The tax credits for the premiums are on a graduated scale. So the higher your income, the lower the percentage or the lower the amount of the credit would be. Most of them top off at that 400% of poverty level at about 9.5% of your income. That's what you would pay for, and this is another important distinction. There are 4 different levels of plans, and they're called the precious metal plans. There's the platinum, the gold, the silver, and the bronze. The tax credits are based on the second lowest priced silver plan. So when we talk about how much the tax credits would be, that's what those would align to, that second lowest priced silver plan. There would also be cost-sharing subsidies to help with the out-of-pocket costs, the co-payments that would be associated with the insurance. And individuals who aren't eligible for the credits, if they're offered coverage by their employer, unless the employer plan doesn't meet certain minimum percentages, the employer share it would be 9.5% of income. So there's some ways of making sure that that individuals have this coverage even if it's not available through their employer. Small businesses also will qualify for tax credits. The credits for small business, the eligibility requirements are employers who have 25 employees or less and annual wages of $50,000. And there's a formula for calculating what that annual wage is that, quite frankly, I haven't quite figured out yet. But and also the employer has to contribute up to 50% of the total premium cost of the employer's insurance. We have seen a lot of small businesses take advantage of these tax credits already. One of the studies that we've seen indicates that there's a 14% increase nationally in the number of small businesses that are offering coverage. There is an individual responsibility provision. This is probably one of the more controversial aspects of the Affordable Care Act. The goal here is to of the individual responsibility provision is to make sure that the risk pool is as broad as possible and ensure that there's shared responsibility. I think there's a concern among insurers and healthcare providers that unless there's some incentives or some this type of provision, that people will opt out of getting insurance until the classic line is until they're in the ambulance on the way to the hospital. This is intended to try to make sure that people take responsibility for their health care and actually purchase insurance as it's available to them. This is a requirement that U.S. citizens and legal residents have qualifying coverage. There is a provision in the Affordable Care Act that excludes people who are not documented from getting any coverage through the Affordable Care Act. But for citizens and legal residents, there will be a penalty if you don't have coverage. That penalty will eventually be, in 2016, $695 per year, and that would be up to a maximum for a family, that's per person, and for a family up to 3 times that much. So if my math is correct, it's around $2,000 for a family of 3 or more. There's also, it would be the lesser of that amount, or 2.5% of household income. So this is, the penalty is being phased in from 2014 to 2016. It starts out at a much lower level, but that's the level at which it would top out in 2016. There are some exemptions from this provision, the individual responsibility provision. If there is a financial hardship, a person who, and generally I think that's looked at the relationship of a person's income to the cost of insurance, and towards the bottom we say if the lowest cost plan exceeds 8% of your income, you wouldn't be required to buy something that took a significant share of your income. There are religious exemptions. There are health sharing ministries in which the members of the ministry agree to take the burden of each other's health care cost. These ministries would be exempt, and there are some other religions who have just a fundamental opposition to insurance that wouldn't be required to purchase coverage as well. American Indians would be exempt. Their health care needs are to be addressed by the Indian Health Services. Persons who are incarcerated don't have to purchase insurance. And also, the law recognizes that there will be circumstances where you'll be without coverage for a short period of time. If you're between jobs, you lose your employer coverage and haven't picked up something else, that there will be gaps of coverage where you wouldn't be required to have health care coverage and you wouldn't be penalized for not doing so. And also I mentioned the income-related, that if there is a burden of purchasing insurance, then you wouldn't also be required to purchase under those circumstances as well. We do have some insurance reforms and consumer protections related to affordability. There is the prohibition of denial of coverage if you have pre-existing conditions, as Jennifer referenced, for everybody in 2014. The children are covered already. There are some changes in what insurers can look at when they're setting premiums. And from AARP's perspective, age rating is one of those things, where currently in Nebraska we have unlimited age rating. And so if you're 64, typically you pay substantially more than if you're 24. And we'll see some examples of that in a little bit. Insurers won't be able to set different rates based on health status or gender. I mentioned the age rating. There is a limit that we are bringing that down to 3-to-1. Right now in Nebraska, we've seen as much as a 7-to-1 age rating difference for those who are approaching Medicare age in comparison to those who are younger. Tobacco use, there will be rating based on whether or not you smoke, but it's limited to a 1.5-to-1 rate. This is probably one of the key provisions of the Act in terms of affordability, and that's that insurers will be required to use 85% of the premiums on medical claims. There's a limit on how much they can keep for administration and other non-medical claims related costs. That's in the large group market. In the small group market, it would be 80% of premiums that would have to be directed to medical claims. So these are just some of the reforms that will have an impact on affordability. Some of the quality improvements, we'll just briefly mention these. Comparative effectiveness research is something that has, I think, probably got a bad rap as we went through the process of talking about the Affordable Care Act. Really the intent of this, and I look at this in terms of prescription drugs, where you have a lot of different products that are intended to address a certain type of disease, and there's a question about the relative effectiveness of each of those products. At AARP, we looked extensively at the research. We contracted with the Oregon Health Sciences University to look at the relative effectiveness of different drugs within a class, and then compare the cost of those drugs. And what we found was that there wasn't that much difference. The research didn't show that there was much difference, but there was a vast difference in the cost. This is the type of thing that comparative effectiveness research is intended to address. Unfortunately, there was a lot of rhetoric around the issue, and I think we're starting to get back and looking at what possible benefit comparative effectiveness can provide. There's some provisions to do medical malpractice and tort reform pilot programs to look at alternative ways that we can address the whole medical malpractice and torts issue in healthcare. Looking at alternative resolution of problems. From AARP's perspective, I don't think our current system serves anybody particularly well. Persons who have been injured oftentimes have to wait a long time to get made whole. And on the other hand, the physicians and other providers have some concerns about the medical malpractice system. So I think these pilot programs will help us to take a look at if there are alternative ways to make sure that everybody is better served. We're seeing some pilot programs in terms of bundled payments, ways of trying to look at the healthcare system holistically rather than piecemeal, which is kind of the way that we often do it today. We may have, you go to one person for one procedure, another for another, and you see many people that may not be communicating well. Some of the pilot programs that are authorized in the Act will enable providers to share information a little bit more readily so that we can make sure that we don't have some of the problems that arise when we have bad communication. The medical homes, I think we have a pilot project through Medicaid in Nebraska on medical homes, but again, the intent is to make sure that people have a primary care physician who is responsible for their health care and is taking that responsibility and making sure that all of those services that need to be delivered are done so in a coordinated manner and are done so effectively. Primary and preventive care is something that is throughout the Affordable Care Act is a recurring theme that we want to make sure that we have these gateway, the physicians who are managing care for all persons, and especially in the Medicaid program. There's a focus on research and looking at health disparities in different racial groups, income groups, and others to make sure that everybody is receiving the best possible health care. And also a focus on, again, the prevention, health promotion, and public health to try to prevent disease before it becomes so expensive to treat. And again, along the same lines, providing grants to small employers for wellness programs. This is, I see one of the main approaches of the Act is to try to focus on prevention so that we don't have to focus on disease treatment. So, we'll talk about the establishment of the exchange.
So, there are some really key dates that are important to know as we think about moving forward. On January 1st, 2013, under the law, if a state wants to set up its own exchange, and I think I mentioned earlier that a state has a choice that they can set it up, you can have the feds set it up in your state, or we can look at a regional exchange. Either way, if a state is trying to set up its own, it has to apply to the Secretary of Health and Human Services, federal, so right now Kathleen Sebelius, for certification, basically to say, we've done enough on the planning, we know where we're going with this, and we think we can get it up and running in time, and for her to certify it. And then actually by October 2013 is when enrollment will start. So these deadlines are fast approaching. And as I mentioned before, the Level 2 Establishment Grant, the deadline is this coming June. So if we are planning an exchange and we want to have the money to set it up, we need to apply by the end of June. And January 1st, 2014 is the big date when the exchange really needs to be fully up and running and when we'll see all of those consumer protections and other things really going into effect. In order to be able to apply for the Level 2 grant in June, a state has to have legal authority to create the exchange. You have to show them that the state has actually agreed that they want to pursue a state-based exchange. So, given the timelines under the law, a law would have to be passed this session. Since we are in a short session, it ends in April. The law would have to be passed this session for us to be in a position to apply for that grant in June. One thing we haven't mentioned yet, but I know a lot of people know about, is that there were several cases on the law, the majority of which have been dismissed or the law has been upheld, but there have been 2 in which the individual mandate has been found to be unconstitutional. One in which they said, well, that part is, but the rest of the law goes forward, and the other one where the court said the individual mandate is unconstitutional and the whole thing falls. And several of those have been appealed, and the Supreme Court has taken cert on, I think it's actually 3 cases. They're going to hear argument over 3 days, very unusual, in late March. If you are a lawyer nerd like me, you're pretty excited about it, and apparently they're not going to televise it, but we'll have audio. So get your popcorn. And they'll hear the different issues on each of the 3 days. So that argument isn't even until March. Decision is not anticipated until June. It's just because it would take that much time, and really the Supreme Court tends to issue its biggest opinions in the last 2 weeks in June of its term. So we don't expect to have a decision. Nebraska has joined in the Florida lawsuit. You know, we will, obviously, the AG's office and everyone is wondering what that will look like. So that's a date that I think is relevant because we won't know what the Supreme Court is going to say until we're basically need to apply for the Level 2 grant, and we would have already had to have the authority to do it. So that's why this session is so key. In terms of what other states have done, 39 states and DC have already introduced some form of legislation for exchange implementation. 10 states have enacted such bills. My understanding is 5 states have also done bills with an intent to establish an exchange, even if they haven't actually passed a law that authorizes the establishment. And there are, I think, about 5 others that are pending.
And Nebraska is up today.
And Nebraska, Senator Jeremy Nordquist from Omaha, and actually about 9 other co-sponsors, introduced a bill today. It is number, if you're interested, 835, and it is a bill to establish a state-based exchange in Nebraska. So, and actually there was another one. Senator Pauls, who's the head of the Banking, Insurance, and Commerce Committee, I think it's like 3 bills later, I think it's 838, also introduced a bill to create a state-based exchange. They're different substantively, but at least we've got bills there to talk about, and I think that's really important. So as we mentioned, legislation is required to, there is some question as to whether the governor could just certify or say, hey, we're going to do a state-based exchange, and whether that is enough authority, but most states are passing legislation as their authority. If we do not pass a piece of legislation, or if we are not in a position to apply for the Level 2 establishment grant, it is almost certain that we will have the federal government come in and set up an exchange in Nebraska. And it's our understanding that the federal government intends to go into each state that doesn't choose to set up their own exchange and set up an exchange, not that there'll be this big federal exchange that states go into. So that's the alternative. Several key issues to be addressed when establishing an exchange are governance, and this is a huge piece. What entity is going to run the exchange? What does that look like? Who's involved? This no wrong door policy, which we mentioned, that from a consumer perspective we feel is really key. This is about me being able to walk in there and say, I've got 2 kids, I make this much money, and finding out, oh, you're eligible for Medicaid, or here, look at these private plans, and not being sent somewhere else to go in yet another line, especially from a low-income advocate perspective, when you're talking about folks who it may not be that easy for them to get time off their job or whatever they need to do to apply. Funding, how will the exchange be self-sustaining? Navigators and outreach, how do we let people know about the exchange and who does this work? And adverse selection, which is about healthy markets. So the governance board is required to do several things. It regulates the qualifying health plans is a term that's in the law, and these are basically the plans that are allowed to offer coverage in the exchange. Do they meet certain quality and information disclosure requirements? So this is some of what we talked about before. reviewing their premiums and their performance. So are they, and we do this to some extent now in the regular private market. Sometimes they do rate reviews basically to see, is it sort of outrageous the amount that their rate has gone up? Is there a real reason for it that the insurer can show? The governance board needs to be either a government entity that's an existing state agency or an independent entity that's now set up, or a nonprofit. And there are pluses and minuses to those. It needs to have a majority of voting members. This is actually, sorry, I think I was working off different slides. This is in the regs that are proposed, this bullet, that the majority of voting members, if there is a governing board, the majority of voting members cannot have a direct financial interest in the exchange, basically. You're going to make money off the decisions you make as the board controlling the exchange. And a majority of voting members have to have experience relevant to healthcare, financing, delivery, public health policy, things like that, which I think, makes sense to have a certain level of expertise. They can also have advisory boards also, so you can get some of the expertise that way. They are required to consult regularly with stakeholders and required to be publicly accountable and transparent. You have to have open meetings, things like that. Technically competent leadership. We all like there to be competence in our leadership, so that seems pretty straightforward. And have authority to take the actions that are actually necessary that the federal law requires you to take, and meet security, privacy, and data standards, which I think has not been talked about quite as much, but this is obviously something that people have been talking about even before the ACA in terms of so much going to electronic records. How do we maintain people's privacy while getting the benefit of sharing things electronically? And they have to write rules that comply with federal law. This is just a couple of the possible advantages and disadvantages of what the structure would look like. The benefit of going with a state agency is that there are several things that the exchange is going to need to do that are governmental type functions. So it's sort of helpful in some ways to have at least some relation to a state agency. Open meeting rules would likely apply, and we've got good open meeting laws in Nebraska. There's a potential for more direct accountability, less regulatory duplication. The problem is a risk of an overly politicized decision making in terms of who's actually running the exchange and who's directing that. Instability with changing administrations, depending on whether you've got a board or not. And one of the key things here is, which we'll talk a little bit about, is there is this idea that there should be a board that governs the exchange. You don't have to in every circumstance, but most states are presuming that they'll have a board. There's no clear path if it's just solely in a state agency for consumer input, which I think is important. An independent public agency would have more independence, less risk of being politicized. The board, expert board might be better equipped to address some complex problems, and you're still under the public purview, but maybe there's less direct existing relationships with other state agencies that you would need to work with. And here, the Department of Insurance obviously has a huge role, but the Department of Health and Human Services also has a huge role because of the Medicaid expansion, and they really need to be able to work together on that. And there's some potential for regulatory duplication. A nonprofit entity obviously would be the least politicized, more independent, still would utilize an expert board, but it's isolated more from some of the state functions that might be helpful. And there's still the possibility of regulatory duplication. I think what has been proposed in the bill that we mentioned, 835, that Senator Norquist put together is sort of, I think, kind of a blend of the first two, where you're utilizing as much as you can, leveraging the resources of the Department of Insurance, but there is a strong policy-making, binding authority, governing board that would have a broader range of consumer input and small businesses and different stakeholders there that would have that kind of policy-making authority that maybe helps balance leveraging what is helpful about leveraging existing government entities, but also getting the input from the consumers that we need at the same time. A governing board should be robust and politically independent, as we mentioned, have binding decision-making authority, represent a variety of interests and perspectives and geographic areas and fields of expertise, and since all of that is really important, and I think in Nebraska it's really important, the geographic differences are really important, since there are things that are going to work in Valentine that'll have nothing to do with how it works in Omaha or in Lincoln, and so I think that becomes really important. Having a majority of people representing individuals who will directly gain insurance through the exchange. I mean, this is really about having a majority of consumer representation on the board, which I think is in line with the intent of the Affordable Care Act, that this is really about consumer access to coverage. And having some cultural, racial, gender, and ethnic diversity to really make sure we're representing the unique makeup of Nebraska. Some things that I think have been considered and should be considered as we look at these bills is there a state agency with the resources and time necessary to do this work? How can the exchange maximize funding stability in terms of being self-sustaining going forward? And how will the exchange maintain transparency and public accountability? In terms of other states, there's only one, so this is broken down by, there's one state agency, one state that has decided to just put the exchange fully in a state agency, which is Vermont, except that actually if you read the law, there is still a binding, a board with binding authority in Vermont. And what they actually want to do is experiment with single payer in Vermont. So it's sort of a different situation. West Virginia, I think, is a model that's been looked at here, which is more quasi-governmental, this sort of, let's use the state agencies that exist, but we're also going to have a board. And then only a few have done a nonprofit agency, or are considering it. Hawaii is the only one that's actually passed or enacted a bill. And I'll turn it back to Mark.
Okay, and Jennifer mentioned how do you gain access, the whole process of how you gain access to the health insurance exchange, and the importance of a no wrong door type of an approach. This is, I think, a critical aspect of how, whether or not the exchange will work for consumers in Nebraska or in any other state, because there are going to be circumstances where a person will seek or gain health insurance coverage from the exchange, but their circumstances may change. Remember that it was 100% to 400% of poverty was the range of incomes that are eligible for the premium subsidies, but it's 138% of poverty and below that's eligible for Medicaid. So if I have an income at 150% of poverty and suddenly have a loss of income that takes me down below that 138% level, I need to easily and seamlessly be able to transition from the exchange insurance, which is going to have some out-of-pocket costs associated with it, to Medicaid, which will have less costs associated with it, to take into account the change of circumstances in my income. So this is what the no wrong door approach, or that term, refers to, being able to transition between different levels of insurance coverage easily, seamlessly, to get the best coverage that's appropriate for your circumstances. And the Affordable Care Act does require that a no wrong door policy for enrollment be available for new and existing public health care options. So if again, Medicaid, Kids Connections, the tax credits, all of those optimally need to be able to work together so that a person can move easily from one to the other. The application process also, they can be submitted online, in person, by mail, or via phone, and the no wrong door should apply to all methods of application. And again, this is going to require a lot of coordination between the Department of Health and Human Services in Nebraska, the Department of Insurance, or the exchange, essentially, which, if I think both bills would be housed in the Department of Insurance. So there has to be strong communications and connections between those two entities. We would like to see one application be used to be able to gain access to any of the types of insurance that are available, whether that be Kids Connection, Medicaid, or the tax credits. One of the great frustrations, I think, that consumers have is when they have to enter duplicative information and do the same thing over and over again. So to the degree that we can make this interoperable, to work together, that would make a whole lot of sense from the consumer perspective. Also data matching, and that means being able to take the information that has been submitted, update it, and use it to, again, make the best possible option, provide the best possible option for the consumer. And I think this is especially important in some of the public health insurance programs where, again, we don't want to ask people to have to continue